Hello dear students, today our last lecture of child dentistry, course 5. The topic of this lecture is methods of treatment after the development of the jaw bones, orthodontic surgery. A malocclusion associated with any significant discrepancy in the dentofacial skeleton of an adult requires a combination of orthodontics and surgical repositioning of the jaws for definitive correction. These skeletal problems can include anterior-posterior disproportion associated with the size, position, or with the size or position of the maxilla and mandible in class 2 and class 3 cases. Vertical disproportion associated with excessive or reduced maxillary incisor tooth show increased overbite or open bite, transverse anomalies, and asymmetries of the face and jaws. Orthodontic camouflage may be possible in some cases, but this approach can be compromised and limited by the extent of skeletal discrepancy. Growth modification is not possible in an adult, but many of these malocclusions would be amenable to attempts at treatment with a functional appliance if diagnosed in a growing child or adolescent. However, it should be remembered that these more severe forms of skeletal discrepancy are the ones least likely to respond to attempts at growth modification and often end up requiring a surgical approach. Orthodontic surgery can involve a range of surgical movements which achieve repositioning of the maxilla or mandible within the facial skeleton. Surgery of this kind does not affect any inherent growth capacity that may reside in the jaws, and for this reason it is only carried out once skeletal growth has ceased in the adult. This is particularly important for the class 3 cases with mandibular excess, where continued forward growth of the mandible after backward surgical repositioning can lead to the reappearance of reverse overjet if the surgery is carried out before growth has ceased. Why do adults present for orthodontic surgery? An adult patient will ultimately be advised that they require orthodontics and orthodontic surgery if the discrepancy in their skeletal-base relationship is so severe that orthodontic camouflage either is not possible or would significantly compromise facial aesthetics. Many of adults are unhappy with the way they look, and achieving a normal facial appearance is often a key motivation. Some are more concerned with functional difficulties associated with their malocclusion, such as eating or more rarely speaking. Others are simply unhappy with the appearance of their teeth. It can often come as something of a shock to a patient who is primarily concerned with the appearance of their teeth to be told that not only do they need orthodontic treatment to correct their position, but facial surgery as well. In these instances, surgical intervention may be declined and orthodontic treatment limited to tooth alignment alone, with the patient and orthodontist accepting the underlying skeletal discrepancy. A minority of patients may exhibit a significant preoccupation with an imagined, relatively minor or non-existent defect in their facial appearance, a condition known as body dysmorphic disorder. Any suspicion of this should be elicit referral for a more formal psychiatric assessment prior to embarking on any combined treatment. The acquisition of records and principles of treatment planning for adults with marked skeletal discrepancies follows the same essential sequence as for any other patient. The primary objective is to position a well-aligned class 1 occlusion within a balanced and proportional facial skeleton. A fundamental difference between planning for surgical correction of a skeletal discrepancy and conventional orthodontic growth modification or camouflage is the extent of predictable change that can be brought about. Jaw movements of up to 1 centimeter can be achieved by the surgeon, which in combination with fixed appliance system that allow precise tooth positioning, means that significant malocclusions can be corrected with great accuracy. Patients should be assessed within the environment of a joint clinic that involves both surgeon and orthodontist. This allows a preliminary plan to be presented and explained to the patient, affords them the opportunity to ask any question and come to an informed decision with regard to undertaking such treatment. The orthodontist plays a predominant role in preparing a patient for orthodontic surgery. Once it is felt that the teeth are in a position to allow the required surgical movements to take place, the patient returns to the joint clinic and the surgery is definitively planned by the orthodontist and surgeon. Pre-surgical orthodontic treatment include 2 principal aims. Which of these aims is? Eliminate any natural dental-alveolar compensation that might exist for a skeletal discrepancy and therefore allow complete surgical correction. And coordinate the dental arches to produce a well interdigitated, functional and stable occlusion in the final post-surgical position. These aims are achieved within a number of overlapping phases, primarily during pre-surgical treatment through orthodontic tooth movements. Also, occasionally, some surgical intervention may also be required, particularly for expansion or leveling of the maxillary arch. Surgically assisted expansion is carried out before the definitive osteotomy, whilst surgical assisted leveling usually take place it. Some controversy exists regarding the amount of orthodontic treatment that should be completed prior to surgery, but conventional planning requires full decompensation. Orthodontic alignment of the dental arches will be necessary. Space requirements will need to be assessed, and if these are high, tooth extraction may be needed. However, in surgical cases, the planned anterior-posterior and vertical position of the upper and lower incisors can significantly influence these requirements. Extraction may be required to provide space for tooth alignment and leveling. Incisor decompensation or assess for segmental osteotomy cuts. However, it is important to note that tooth movement required for orthodontic camouflage are often directly opposite to those necessary for decompensation prior to surgery, and extraction-based camouflage treatment should be approached with some caution in individuals with significant skeletal discrepancy. A good illustration is extraction of premolars in the mandibular arch of a class 3 case. This will often be required to provide space for retroclination of the lower incisors if orthodontic camouflage is planned. However, if this treatment proves to be unsuccessful and surgical decompensation is subsequently required, the lower incisors will need to be proclined. If premolars have previously been extracted, this will lead to considerable space opening up in the buccal segments. For this reason, particularly in class 3 cases, if there is any suspicion that orthodontic surgery may be required, mandibular premolar extraction should be avoided and any treatment decision delayed until facial growth has ceased. Class 2 cases may require extraction in the mandibular arch if this is any degree of crowding, particularly in this combined with a requirement to upright or intrude the incisor. Proclination of the mandibular incisor is usually undesirable because it will reduce the amount of potential forward surgical movements of the mandible. In the maxillary arch of class 2 cases, crowding is generally less common. Incisor movement rarely requires significant space, and some arch expansion is often desirable. Therefore, extractions are rare. If the incisors are retroinclined, space will be generated as they are moved forward to create an overjet necessary to facilitate mandibular advance. As we said, class 3 cases do not usually require extraction in the mandibular arch. Crowding is generally rare because of the increased arch length associated with an enlarged mandible, and space is often generated as a result of the incisor proclination required for decompensation. In contrast, space is often at a premium in the maxilla arch. Length can be reduced because of a small and narrow upper jaw, and there is commonly crowding. To make matters worse, the incisors often require some retroinclination, which requires space, and therefore premolar extraction are often needed. The final labiolingual position of the incisor teeth is important because it will dictate the amount of surgical movement that can take place in the anterior-posterior dimension. Any existing dental-alveolar compensation that would restrict this movement needs to be corrected prior to surgery. Inevitably, these incisor movements can lead to considerable worsening of the malocclusion during the period, and the patient should be made aware of this before treatment begins. Class 2 cases often require maximal forward movement of the mandible, and this is achieved by ensuring an overjet is presented, like here. retroinclination of lower and occasionally some proclination of the upper incisors can be required in class 2 division 1 cases, whilst in class 2 division 2 cases a significant amount of upper incisor proclination is usually required. Class 3 cases are often associated with the opposite situation. The upper incisor are proclined, whilst the lower are retroinclined, and presurgical orthodontic treatment mechanisms are required to reverse this position and produce reverse overjet. An excessive or reduced curve of speed in either the maxillary or mandibular arch will require leveling if good interdigitation of the teeth is to be achieved in the final occlusion. This can take place at one of 3 time points during treatment, and choice of mechanisms will be dictated by the method of leveling employed. A decision to level the arches using orthodontic treatment mechanics prior to surgical treatment usually take place in the absence of severe discrepancies in either of the occlusal planes. Leveling can be achieved with incisor intrusion, molar extrusion, a combination of these two movements, or more rarely incisor proclination. With mandibular surgery alone, leveling a curve of Spee with incisor intrusion will result in the lower face height being maintained following surgery and is usually planned for patients with acceptable vertical proportions. In the patient requiring posterior impaction of the maxilla to correct and open bite, care should be taken if orthodontic leveling of a reduced curve of Spee in the maxillary arch will involve excessive extrusion of the incisors. Following surgery, any vertical relapse of these teeth will result in a tendency towards reopening of the open bite. Arch leveling during segmental surgery. Occasionally, the vertical discrepancy is so severe that segmental jaw surgery is indicated to achieve arch leveling. This is more common in the maxilla in association with a markedly reduced curve of Spee and anterior open bite. If a decision is made to correct this with segmental surgery, the orthodontist will use segmented arch wires to level the teeth within segments and ensure that the vertical discrepancy is maintained prior to surgery. Space will be required between teeth adjacent to the planned segments to allow for vertical osteotomy cuts, and premolar extraction are often required to create this. Class 2 cases Class 2 case with reduced lower anterior face height are often associated with an increased curve of Spee in the mandibular arch. It is desirable to increase the lower face height in these cases as the mandible is advanced, and this is achieved by maintaining the curve of Spee prior to surgical movement. The lower incisor position ensures an increase in face height as the mandible is advanced and the arch is subsequently leveled by extrusion of posterior teeth during the postsurgical period. This technique is known as three-point landing because in the initial postsurgical position, there is only tooth contact between the incisors and posterior molars. Clearly, in these cases, it is important that the orthodontist maintains the curve of Spee in the mandible prior to surgical repositioning. The final stage of orthodontic preparation ensures that the dental arches are coordinated in the transverse plane following surgical movement. In the proposed surgical position, there should be an absence of crossbites and good interdigitation of the buccal segments from the canine teeth back. Transverse coordination is almost always achieved prior to surgical movement. Class 2 cases requiring mandibular advancement often need some expansion of the maxillary arch to compensate for the relative increase in the transverse dimension of the mandibular buccal segments as they move forwards. This is usually achieved by dental expansion with orthodontic arch wire, or in more severe cases, expansion with a quad helix or rapid maxillary expansion appliance. Class 3 cases requiring mandibular advancement often need some expansion of the maxillary. Class 3 cases are often characterized by a narrow maxilla, which will require expansion even though our relative anterior-posterior surgical movements between maxilla and mandible may favor transverse coordination. Depending upon the degree of maxillary construction, these can be achieved with orthodontic or occasionally surgically assisted expansion. Final surgical planning. The presurgical orthodontic phase of treatment is usually regarded as being complete when the orthodontist has achieved the following goals: alignment of all the teeth with rigid rectangular stainless steel arch wires present in both dental arch, upper and mandible, maxilla and mandible. Correct incisor position in the anterior, posterior, and vertical dimensions, and demonstration by snap dental casts of arch coordination in a class 1 occlusal relationship. This is confirmed following examination of the patient on a joint cleaning with a new set of comprehensive records. In particular, a cephalometric lateral skull radiograph and profile photograph. Together with the patient, these records are used to plan in detail the surgical movements required to correct the malocclusion and simulate their effect on the soft tissue facial profile. These predictions can be carried out manually by hand or with the aid of computer software. In the case of manual prediction, the orthodontist carries out the proposed jaw movements on the cephalometric radiograph and reproduce the soft tissue changes using profile outlines, templates, or superimposed photographs. Computer prediction programs allow the process to be carried out electronically, which theoretically should produce more accurate profile prediction, although this is not necessarily the case. However, a problem with all these methods is that the soft tissues do not respond to the surgical movements in a simple ratio, and changes can vary in different regions of the face and between individuals. More recently, three-dimensional surgical planning has been advocated, but whether this is any more accurate than planning based on the profile remains to be seen. Once the surgical movement has been planned, articulated study casts are required to allow the dental technician to simulate them in the laboratory. For single jaw mandibular surgery, an acrylic wafer is constructed on models articulated in the planned final occlusion position. This provides a positional guide for the surgeon at operation. Surgery involving either the maxilla in isolation or the maxilla and mandible requires a face-ball recording, which allows the technician to mount the maxillary dental cast on a semi-adjustable articulator. The mandibular dental cast is then articulated in the retruded contact position, RCP, and the mandibular hinge axis is reproduced. The technician simulates the planned maxillary osteotomy and constructs an intermediate wafer which uses the original mandibular position. The surgeon uses this wafer as an aid of positioning the maxilla during surgery, which is why an accurate reproduction of the condylar axis is required. For bemaxillary surgery, the technician will also construct a final wafer for the surgeon, which reproduces the planned final occlusion position of the mandible. The maxillofacial surgeon is responsible for repositioning the jaws in accordance with the surgical plan. Advances in anesthetic and surgical techniques mean that there is now increased scope to position the jaws optimally within their soft tissue envelope. The use of biomaxillary surgery to reposition both the maxilla and mandible has made surgical compromise less common and increased the range of malocclusion that can be corrected. The envelope of discrepancy showing the tooth movements theoretically possible for correcting a malocclusion, with the ideal position shown at the origin of the X and Y axis, the movement possible with orthodontics alone, inner black envelope, gross modification, middle red envelope, and surgery, outer red envelope are shown here in the picture. rigid internal fixation mediated by small bone plates and screws has reduced postoperative discomfort, improved safety for the patient by avoiding the need for postoperative maxillomandibular fixation, and improved long-term stability of the final result. A number of surgical procedures are commonly carried out to alter the position, width, and occlusal plane of the maxilla. Lefort 1 osteotomy. The entire maxilla can be moved in anterior-posterior, vertical, or transverse direction at a single unit with a Lefort 1 osteotomy. These movements can be carried out using a single vector or with a combination to produce differential changes in position. Lefort 1 involves disarticulating the maxilla from the skull by cutting along the lateral outer wall through the base of the zygomatic buttress, extending anteriorly to the piriform fossa and posteriorly to the pterygoid plates. Internally, the nasal septum and lateral wall of the nasal cavity are freed, with the maxilla being finally mobilized by separating it from its attachment at the pterygoid plates. The surgeon achieves superior vertical repositioning by removing bone in the region of these cuts, whilst inferior movements require grafting into the intervening space. The maxilla can be moved forwards or upwards by anything up to 10 millimeters, and these movements are generally stable. Backward repositioning is also possible, but the changes that can be achieved are less at around 5 millimeters. Inferior repositioning of the maxilla is notoriously unstable and generally avoided. Segmental maxillary osteotomy. Segments of the maxilla can also be moved by surgeon Easier is an isolated procedure, or more commonly in combination with Lefort 1 osteotomy. Anterior subapical osteotomy achieves isolated movement of the canine and incisor teeth for easier reduction of an overjet or correction of a vertical discrepancy, usually anterior bite. Posterior subapical osteotomy is occasionally used for isolated correction of an unilateral posterior crossbite. And following Lefort osteotomy, The maxilla can also be divided bilaterally to facilitate correction of a transfer discrepancy, usually expansion for bilateral posterior crossbite, or segmented into 3 pieces for leveling an occlusal plane during the correction of vertical discrepancy. These segmental procedures often require some room between relevant teeth, which provides surgical access for the necessary cuts within the alveolus. This is usually achieved by premolar extraction, or less commonly by increases in arch length and root paralleling mediated by the orthodontist. Mandibular procedures. The body of the mandible can be advanced or moved backwards in relation to the ramus, or this movement can incorporate the ramus. In addition, chin prominence can be adjusted with localized osteotomy along the inferior border. Sagittal split osteotomy includes the bilateral sagittal split osteotomy, or BSSO, is used to move the mandible forward or backwards in the treatment of retrognathia, prognathia, or asymmetry. A medially positioned cut is placed into cortical bone of the ramus just above the lingula, whilst a laterally placed cut is fashioned through cortical bone of the body in the region of the molar dentition. These cuts are then joined by splitting the mandible along a line extending through the cortex, which allows forward or backward movement of the body in relation to the ramus, but maintains patency of the neurovascular bundle. The mandible can be moved in either a forward or backward direction using bilateral sagittal osteotomy, or BSSO. Both these movements demonstrate good stability, particularly mandibular advancement. Also, the upper limit is around 10 millimeters. Vertical subsigmoid osteotomy. The vertical subsigmoid osteotomy is used primarily to move the mandible backwards for the correction of mandibular prognathism or asymmetry, and involves a cut from the sigmoid notch in front of the condyle, extending vertically down behind the neuromuscular bundle to the angle of mandible. Genioplasty. The genioplasty is an osteotomy involving the inferior border of the chin and is achieved with a horizontal cut across this region. The body segment can be moved in an anterior or posterior direction to augment or reduce chin prominence, whilst vertical reduction can be used to diminish the height of the anterior mandible. Genioplasty can be used in isolation to correct mild problems of chin aesthetics, particularly asymmetries. However, it is most commonly used as an adjunct to BSSO, easier to reduce chin prominence or to increase it. Anterior subapical osteotomy. The anterior subapical osteotomy is occasionally used to alter the position of the lower labial segment in the mandible and requires vertical cuts through the alveolus behind the canine teeth, which are joined by horizontal cut underneath the root apices to free the anterior segment. The subapical osteotomy can be utilized in the correction of anterior open bite and bemaxillary preclination, or for leveling an excessive curve of Spee if this cannot be achieved orthodontically and the anterior face height needs to be maintained. During post-surgical orthodontic treatment, we usually initiate it within 2 weeks of surgery if rigid fixation has been employed, and often begins with removal of the final surgical wayfare. Up to this point, the final wayfare in combination with intraoral elastics placed in theater has maintained the occlusal position whilst normal function is re-established. This final period of orthodontic treatment is concerned with establishing ideal occlusal relationships and maximum interdigitation of the teeth. During this period, flexible arch wires are placed by the orthodontist and elastic wear is prescribed according to the final adjustment required. The duration of this treatment will depend upon the amount of tooth movement still required. In cases where arch leveling has been achieved either prior to or with surgery, the post-surgical phase is usually only concerned with final occlusal detailing. In contrast, post-surgical leveling can take a little longer, but in most cases, a period of no more than 6 months of post-surgical orthodontic treatment will be required. Distraction osteogenesis. Distraction osteogenesis, or DO, in the craniofacial region is a technique that involves osteotomy of either the maxilla or mandible, followed by progressive mechanical separation of the bone fragments using a fixed expandable device. An advantage of this technique is that it allows jaw movement in considerable excess to that which is achievable using conventional orthodontic surgery. For the treatment of patients with severe jaw deficiency, particularly those with syndromic craniofacial disorders, distraction osteogenesis can afford great potential for more stable correction of the skeletal discrepancy. The success of distraction osteogenesis when applied to the membrane-derived bones of the facial complex relies upon the applied tension across the initially soft callus of the fracture site, resulting in the creation of new bone. An important principle is to allow a latent period of 4 to 5 days following the osteotomy before any tension is applied. This results in the production of a soft callus and optimal bone formation during destruction. Also, osteodestruction has gained widespread use in the maxillofacial region. Over the past 10 to 15 years, most reports and meetings have focused on the application of destruction osteogenesis to significant craniofacial deformities and syndromic patients, with few clinicians using the technique for the interdisciplinary surgical, orthodontic, restorative procedures commonly seen in private practice. The following clinical cases demonstrate the use of osteodestruction for treating various types of bone deficiencies, maxillary and mandibular deficiencies. Furthermore, these cases demonstrate that the use of destruction osteogenesis does not preclude obtaining high-quality facial aesthetics and an ideal functionally based occlusion. That is a bilateral mutually protected occlusion especially maximum intercuspation having canine guidance in lateral exclusion and incisal guidance in protrusion with the condyle located in a centrically related position. And destruction treatment planning is perhaps the most critical step. Once the dental arches have been aligned, ideally, the orthodontist should obtain patty-based dental casts to ensure that the maxillary and mandibular arches, which should be ideal independently of each other at this point, can be intercuspated ideally together. At this time, dental spacing, if necessary, should be confirmed by the surgeon who will be placing subsequent implants and the restorative dentist who will be placing definitive restoration. Assuming that all clinicians feel the dental arches are set up ideally, pre-destruction records, which are similar to pre-treatment records, are obtained. This process is necessary to account for any skeletal, including growth or dental alterations that have occurred during treatment. Two additional methods used commonly at this stage are articulator-based devices that allow manipulation of the dental cast to predict and determine the amount of skeletal movement in all three planes of space, and stereolithographic models generated via computed tomography data. These models allow the fabrication of the destruction device and the manipulation of the bone segment with the fabricated device. Once the desired movement has been achieved, a period of consolidation is required to allow maturation of the newly formed bone and stabilization of the new jaw position. It is clearly important during destruction osteogenesis to carefully control the vector of surgical movement. Common malocclusions and their surgical treatment. Isolated mandibular deficiency often manifests as a class 2 division 1 malocclusion in the presence of a normal or increased lower face height and a class 2 division 2 incisor relationship with a reduced lower face height. The approach to surgical correction of these problems will involve forward movements of the mandible, usually achieved with BSSO, bilateral sagittal split osteotomy. However, the vertical relationship will also influence the treatment plan, and if a significant increase in the lower face height exists, some posterior impaction of the maxilla may also be required to allow mandibular autorotation and a reduction in this dimension. If the face height is normal, the mandible will be brought forward with a level occlusal plane, like here, and maintains of the existing vertical dimension. If the face height is reduced, as in this patient in class 2 subdivision 2 malocclusion, the curve of SPI is generally maintained in the mandible and the post-surgical face height increased with the osteotomy. When moving the mandible forwards, the chin position should also be considered. Some reduction may be required if the chin point is prominent in the correct surgical position or augmentation with marked micrognathia. Class 3 cases can be associated with varying amounts of maxillary reduction, with varying amounts of maxillary retrusion and mandibular prognatism. Either alone or in combination, and will require corresponding anterior-posterior movement of these jaws, often via leftward 1 and bilateral sagittal split osteotomy. Significant variation in the lower face height can also be seen in combination with a class 3 malocclusion. And if Excessive may require maxillary impaction in combination with anterior-posterior change. It should be remembered that maxillary impaction is also associated with mandibular auto-rotation, which can be beneficial in the correction of class 2 discrepancies, but will tend to worsen a class 3 relationship. Additional vertical problems, easier in isolation or combined with an anterior-posterior discrepancy, often require maxillary impaction. These can include problems of vertical maxillary excess and a gummy smile or anterior open bite, and may require easier one-piece or segmental maxillary surgery to correct the vertical incisor position. And advances, I want to speak about a little about the technological advances in orthognathic surgery. Advances in surgical techniques have improved the predictability of favorable outcomes for patients undergoing orthognathic surgery. First, anesthetic technique. Now it's modified hypotensive anesthetic technique has given the surgeon the ability to perform complicated orthognathic surgical procedures in highly vascular areas with minimal blood loss. Edema control is also very important during orthognathic surgery. Post-operative swelling arising from orthognathic procedures requires special attention. Excessive swelling can lead to limited mandibular function, swallowing difficulties, pain, and airway obstruction. Measures for controlling edema include minimizing surgical trauma, shortening operating time, maintaining careful hemostasis, and ensuring pharmacologic control of the inflammation process. Infection control also is very important. Infection is an uncommon occurrence after orthognathic procedures. However, when infection does develop, it usually is a local inflammation that responds well to incision and drainage and systemic antibiotics. Surgical procedures itself, oral and maxillofacial surgeons have studied the effects of a variety of surgical techniques over the past years. Over the past 30 years, 20-30 years, the following criteria generally are considered in determining which technique best serves the patient's needs: safety of the technique, reduced morbidity, stability of the procedures, enhanced rate of healing, reduced surgical time under anesthesia. And of course, it's very important to make proper orthodontic treatment and skeletal orthodontic post-surgical treatment. because the main problem with many orthodontic retreatment patients appear to be significant differential growths that lead to class 2 open bites, maxillomandibular transfer discrepancies with posterior coarse bites, or class 3 type occlusal problems. And as specialists, orthodontists know that these are difficult growth patterns to manage. Although many of these malocclusions can be corrected with orthopedics and good compliance, many cannot. Therefore, the orthodontist is obliged to diagnose in all three planes of space, to discuss therapeutic modifiability of skeletal imbalances openly, and to present this possibility of a surgical phase if compliance or the growth response is inadequate to achieve an optimal occlusal result with acceptable facial balance. That's why it becomes critical in this case to communicate more clearly about treatment progress, treatment outcome, and the risk of instability with the patient. And thank you for today, and I hope to see you soon. Stay safe. Goodbye.